You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Adriane Carrier is a dedicated advocate for social justice and health equality with a long-standing commitment to making a difference in people's lives. During the HIV AIDS crisis in the 1980s, she was active in fighting for equal access to healthcare as a civil rights issue. As a campaign lead for the Human Rights Campaign and the community organizer for the Los Angeles Gay and Lesbian Center, Adrienne focused on LGBTQ and minority health issues, fundraising, and legislative work. Later, as part of the organizing staff of the Service Employees International Union, she contributed to historic union organizing efforts for healthcare workers in Southern California in the early 2000s. Adrienne became an RN in Southern California, where she provided care to mostly underserved populations while serving as a union steward. During the COVID-19 pandemic, she worked as a director of education, health, and safety for over 10,000 RNs, writing over 200 regulatory complaints related to safety standards, and collaborated with Cal OSHA to write emergency COVID legislation. Adrienne owns and operates Trusted Guardian Patient Advocates, offering private concierge patient advocacy, health coaching and clinical navigation, medical billing assistance, and family mediation services. She's a board member of Pulse CPSCA, and she also recently launched a podcast, Being the Space, interviewing and discussing change makers, innovators, visionaries, and transformation. Adrienne, thank you so much for being on the Patient Advocacy Now podcast. With a bio like yours and all the experience from legislation to being a nurse to dealing with regulation and safety, you have a pretty big scope of understanding this space. Where do you decide to focus your energy? Because it seems like you kind of have had your hand in so many different pies.
Mm-hmm. Yeah. Welcome, John. Thank you. Yeah, I have a very good big picture view of healthcare and public policy because of my own personal experiences, my professional experiences. And I mean, this is going back to when I was a teenager. So I was an activist at a very young age, thanks to my mom, and just the community and the context. I mean, when, things are happening in our environment, we always have the opportunity to step up, to show up, and to be engaged in change. Now, one thing that's really been, different for me is I went from this policy world to Bedside, and then left that, went back to a much bigger role in policy and education, and had to pivot. And just to clarify, I got hired to be the director of education, and this was just prior to the pandemic really getting going, starting and lockdowns happening. And so the job I thought I was going to be doing, and then the job I ended up doing, were completely different things. And I mean, I literally started the week of lockdowns. So everything I had planned and anticipated and was excited about for my role really went out the window, and I had to shift. And a lot of what we do in life it's about, do we successfully pivot and adapt?
Well, tell me a little bit about the role that you had, what you thought it was going to be, and then what it became. It's always interesting to hear that journey.
Yeah. And again, this is about how the path, sometimes you don't have control over the path and things happen. And it is really more how you work around it. I was hired to be director of education for 10,000 nurses, also a few hundred social workers, pharmacists, physical therapists, other healthcare professionals.
I guess once you reach 10,000, they're like, hey, what's another few hundred, Yeah,
primarily a registered nurses union. But I did have to dabble in also learning about all these other professions and their, professional requirements for licensing, et cetera, to offer classes. So I was prepared to do that and offer continuing education courses, classes on, clinical skills, charting. I thought this is going to be great. I'm going to have fun. I love working with nurses and especially across this huge area of Southern California. So it was, different hospital systems, different types of nurses, some, outpatient, inpatient. So anyways, I, had this expectation, excitement. COVID hits. I had an idea COVID was coming. It wasn't really a surprise to me. I remember pulling my boss aside, my future employer aside, about a week before I started. And I said, hey, there's something coming and it's going to be big. It's going to be really bad. There's going to be a lot of division in the public. We're going to have a lot of pushback from employers, hospitals. There aren't going to be any good players, and we're going to lose members. And we're going to have to be prepared for that, which, none of those things could we be prepared for. Yeah, from a union perspective, you're used to fighting with the boss and, having these battles over contracts and other issues. However, the level, magnitude, and the speed at which COVID, came upon us as a society was completely overwhelming, and for everybody. And I will say that even some employers, they just didn't have a clue what to do, even though there were already policies and regulations in place in California from 10 years prior. What we learned is that when you allow companies to self-regulate, it doesn't always work too well. And so the stockpiles that hospitals were supposed to have, they didn't have the procedures, all that didn't happen. So, given my own experience working in public policy, I just immediately dove in and I became an content expert on airborne transmissible disease, and just immediately went to Cal OSHA, which is a great resource in California. It's our, local version of OSHA, and started just contacting people and writing emails and reaching out to any name I could find that was in that division dealing with hospitals and healthcare, because this will help people understand. Most governors provided kind of blanket immunity under the licensing agencies for healthcare facilities. So that meant all the patient protections that were in place were now gone. So there was no going to a licensing facility like California Department of Health or whatever it may have been and saying, hey, there's issues with patient care. There's XYZ happening. All of that was suspended. However, OSHA was not suspended, which protects workers. So for me, it was about how do we get this angle in that also protects patients as well as the workers, the employees. And that was really the ticket. It was going through OSHA, getting involved with them. They were very excited to, have me on board, have the presence of the union I worked for, which is the largest union in America, and also to have a direct channel to workers on the ground and nurses on the ground who were dealing firsthand prior to anything really being publicized, prior to us even seeing what was happening. We started to see New York. That was in the news a lot. We didn't really see a lot of what was happening in LA and Southern California. And so I was able to bring the voice and the experiences of all these nurses and healthcare workers back to Cal OSHA and say, here's what's going on in 20 different employers, right? Not just one employer, all of them. And it's very similar. Some are a little worse. Some are suspending nurses. Some are firing nurses because they want to wear masks. They're actually making it, a punishable offense as an employee to wear a mask in the beginning because there was a reaction of public relations took precedence over the safety and health of the public, patients, and employees in a nutshell. And so when you start from that place, that's not the kind of place you want to start to when you're dealing with a public health crisis. You know?
Especially at a hospital.
Right. And so, we had doctors that were buying PPE for nurses in the ER. Everybody who in healthcare, most of us knew that this was an airborne issue. So we weren't really too worried about all the other types of transmission. For something to spread this fast, most of us knew it had to be airborne. And that meant having really specialized masks, N95s, which we know went in short supply. So it really became me going around to different people I knew and asking for donations and ordering masks from China. That was really one of the very first things I did was just to say, hey, can you give me $1,000? Can you give me $500? We need to order masks and get the, Chinese version of an N95. And then I took, these thousands and thousands of masks I had in my garage and just started delivering them, driving around to hospitals, facilities, nurses' homes, dropping off care packages saying, here, wear this. Because, again, nurses were being told, here, wear one mask for 5 days, which you can't reuse an N95. You can't reuse a mask that's disposable, meant to be disposable. So there were just so many issues right at the beginning. So then I got very involved. Unfortunately, as I had said, I knew sadly we would lose members, we would lose nurses and we know retrospectively we lost thousands and thousands of healthcare workers, tens of thousands of healthcare workers, whose lives to this day still have not been really talked about, or really they're not celebrated as heroes and really almost sacrificial lambs within a system that didn't want to address the crisis happening. And all of it was fairly preventable, which is also very sad. So we had a death of a nurse early on in April and in 2020. And from there, I had already made contacts. This was now a month and a half in to me working, right?
Mhm.
Doing this role, having left Bedside. I'm in contact with OSHA. It was just something about this individual, what happened. She was in a code doing chest compressions directly. You're standing directly over a patient. Their face is right there. So they're exhaling right into your face. You're pushing their chest down. A lot of air is coming out. And so from that, it really gave me the impetus of, okay, we've got to use OSHA and we've got to use the regulations we have and publicity we can gather from the public and different communities to really bring about change and drive change. And again, I want to say some hospital systems were very, very cooperative, very welcoming of any help and support or guidelines that I could offer. And I wrote a lot of FAQs, fact sheets, guidelines for hospitals that I've just freely handed out. We were like, here, we're all in this together. That was our approach. We did not want to have an adversarial relationship with any employers or anyone, because that was not going to save lives. Saving lives is about collaboration, teamwork, and let's all put our heads together. So there were definitely some systems who were very welcoming of that and relieved, because they really had nothing. They didn't have the people power in place even to run the kind of programs that they needed to run to protect, their employees, or even get PPEs. And we were able to actually procure PPE masks from the governor's office, from the California stockpile, for the hospitals where our members worked. So that was a huge, huge win for everybody, because now we're sitting on thousands of masks that we were now delivering directly to hospitals, hoping that they got to the right people, So that was a big change. So I started writing. I had already been very well versed in writing complaints to Department of Health as far as the licensing issues when it came to patient safety. And so I just switched gears and figured out how to mass produce complaints against hospitals, because one of the things that had happened is way back, and this is where these regulations came about in California, when H1N1 had come about, and I think this was about 2011, 2010. I was a rather new nurse. The problem with that was nobody filed complaints. So on the record, it looked like, great, these hospitals are doing great. Everything's fine. Everything went well. There were no problems at all. And I was working during that time. And I was, I remember, many of my colleagues remember, there were lots of problems. We didn't have enough PPE then, which is why the state created the standards they did, the aerosol transmissible disease standards. So in my mind, I thought, okay, we've just got to generate a lot of complaints so that there is something on the record historically for this period of time, however long this is going to last.
So moving from that COVID period to today, how did you kind of jump into the private advocacy space, and what do you find yourself focusing on as an advocate?
Sure. So I took the exam to be a board certified patient advocate in 2018 when I was still working bedside. I really didn't know what I was going to do with it. I mean, all nurses are advocates. That's our training. It's we understand the ethics and all the bits and pieces of providing advocacy and fighting for our patients to get the best care. Fast forward, went through COVID. COVID was still going on. I was frankly just emotionally drained from working round the clock. And I knew that I needed to give myself a break. So I took some time off. I wanted to think about, okay, what do I want to be doing? What really feeds me? And working with patients, I love patients. I didn't want to go back into a hospital at that point. And I thought, well, I have this credential and it looks like people are starting to create a business out of being a private patient advocate. So I'm going to give this a try. Then I ended up actually moving across country. So, which was really a big shift for me. And it's been a challenge. I'm not going to lie. When you move to a new place and you have no connections, I tell my friends, I said, I'm like a lab experiment. I've just dropped me in some place where I know nobody, have no, provider connections, doctor connections, hospital connections.
Yeah.
And
Where do you
then
live too?
so I live in Virginia. I do provide services nationwide. I mean, really globally, frankly, because it's all remote at this point. So that was really, I thought I'm going to do this entrepreneur thing. I'm going to give myself the time and space to develop my company, which I still am. I mean, as anybody who's listening knows, when you're an entrepreneur, you're starting your own business, especially as a solo entrepreneur, it can take years to really create the level of clientele. I mean, 4 or 5 years where you are a sustainable business. And I think that's something I don't see a lot of advocates understanding, because most advocates are not coming out of an entrepreneur business background. I mean, I'm still learning to understand it and, saying, oh, I got to redo my whole website. Oh, that I made that form terrible. This, what's my marketing? What's my branding? All of the bits and pieces, because you wear 25 hats as a solo business owner.
Yeah, that's for sure. Do you find that you focus on specific services for LGBTQ individuals or for other marginalized communities as an advocate to make sure that they get the best possible healthcare experience, because you've had your own experiences in that world yourself? So I'm kind of curious to see what you would focus on for those communities.
Sure. I think right now, especially in the last couple of years, the healthcare needs of the LGBTQ communities, and I'm going to say there's multiple communities because the intersections are huge. It has really become very challenging, especially in certain states. I mean, people are having to relocate. It already was an issue of equity and people being respectful, even in major metropolitan areas. I mean, I'm a native, Angelino, and I've had my own experiences throughout my life of dealing with homophobia within healthcare or bias. I saw it in my own hospital I worked in. I saw it from coworkers, unfortunately. And yeah, I think that.
Would you mind going through an example either of your own life
Sure.
or one of your clients, so that
Sure.
people who don't deal with it can hear what it sounds like or what it looks like?
Sure. I think, so here's just an example. Now, I came out when I was pretty young. I was 13 when I came out. So, I remember every single time I was an athlete. I often was in the emergency room. I'm prone to be injuring myself and be clumsy.
Right.
The first thing they ask you in a doctor's appointment or emergency room, if you're female, is, can you be pregnant? Are you pregnant? Is it possible to be pregnant? They're asking reproductive questions, which is really an assumption of heterosexuality. Now, yes, I could be gay, a lesbian, and still be pregnant. Absolutely, of course, right? However, it's just that assumption of starting off and not really asking or collecting the data of, who are your partners, what's going on. I think for women, there are some real specific issues, especially when you're doing, your OBGYN appointments. Again, that's another area. What kind of birth control are you using? Well, I'm using the best kind. I don't sleep with men, right? I mean, that was always my answer after about the age of 15. And, again, my mother, I get my sarcasm from my mom. She was a New Yorker. All the way to, oh, I'm not comfortable seeing you. I don't, this is not my area of specialty, from providers to just not wanting to really address the issues of that, women might face, lesbians may face, gay men are going to face a different issue, right? Men who have sex with men are going to face different issues. And then if, you're a person of color on top of that, or you're poor, then you've got all these different barriers and hoops, and you really don't know who to trust. So I don't specialize in those populations, but I certainly am an inclusive practice, and I'm pushing on other advocates to really get more out there behind, health equity, because this is a big issue, and it's not getting any better. Unfortunately, we're going the wrong direction.
As far as safety goes, you talked a lot about that in the COVID protocols. Do you have any examples, either pre or post COVID, of things you've seen at a hospital or in a healthcare situation as an example of dangerous behavior, and how, you can step in and rectify that situation?
Yeah, I mean, on the macro level, one of the things, because of my background, that I really want to drive home to everybody and to other advocates and anybody in this healthcare space is that when we improve the working conditions of healthcare workers, we improve patient care, we improve patient safety. And specifically on the clinical side, when, hospitals for the last 10 years have been cutting nurses' aides, secretaries, and RNs are now just doing everything. As an RN, I was central supply. I was a secretary. I was answering the phone. I was answering the door. I was taking calls, talking to doctors that wanted to have information about patients that weren't mine, because there was nobody else to navigate this. And I was working in a state with ratios where we had, a maximum number of patients. So I will say the biggest safety risk right now to patients, besides lack of actual health care or lack of providers to see, is patient loads for nurses, is that we have to have ratios for nurses. And I would say the second biggest thing is the rampant violence in healthcare that's happening, that's not being addressed by state and federal legislators.
Violence? Did you say violence?
Violence, yes. So, I mean, we've had shootings in hospitals and doctors' offices. There's been no less than 24 healthcare workers killed inside of hospitals or even doctors' offices. Doctors themselves
I haven't heard of most of this. Wow.
Yeah, so this has become, and this is, an issue. I will say the hospital I worked at was on a campus a square mile, for example, and we had 2 or 3 security guards on at any time. So if you can imagine like a football stadium, and you've got, multiple floors inside, plus you've got multiple parking lots all the way around the facility, and cameras that don't cover, the whole area, that's insufficient. So part of it is hospitals have to get more security and really have better measures. I mean, we went from a period, 20 years ago, let's say, where we really controlled patient visitor access in hospitals to, this obsession with patient satisfaction scores, age caps, and part of that was related to visiting hours. So then it flipped and it was like, oh, we're going to have 24-hour visiting hours. There's no, timeouts, no blackout times during shift change, which is a very dangerous time for visitors to come in. For patients, don't come visit your family member at shift change. Don't do it. Because if you're asking the nurses what's going on, you're actually interrupting their ability to transfer information about your loved one so that their care is continued as it should be. So those are some of the issues I would say that are on the macro level. And many of us, so what most people don't know, nursing itself is the most dangerous job in America. Nurses experience the highest rate of workplace violence of any profession, and nurses have the highest rate of workplace injury of any profession. So when you marry those two together, you're basically just, you're taking your, chances that eventually you're going to be a statistic of a violent act upon yourself or an injury in your job. And
where does the violence come from? Because I've never seen it. I can imagine in the ER, if when emotions are high, I can kind of see that. But I'm kind of dumbstruck. I apologize that I haven't kind of jumped in sooner, but nobody's talking about this. Where does the violence come from? Yeah.
Right. These are patients. So, if you if somebody comes in and they have a weapon into a hospital and they're getting aggravated with a nurse or a member of the staff or provider, that's a risk to patients too, right? I've had patients come out of their rooms and say, hey, do you need me to call the police? I've myself called the police. And this is kind of healthcare's dirty secret. They really bully healthcare workers, especially nurses, from reporting this. They don't want us to call the police, although we have every right to do so when we're threatened. And this is something that I, had no issue with. I just told people, look, I will
Why
call the
don't they
police.
want you to call the police?
Because they don't want that reported on their, because if I'm a hospital, right, and I'm in a community and the police have to come out to my hospital, even though I have security, the police are going to start asking the operators of that hospital, hey, what's going on in your facility?
Right.
So if you can imagine if
They don't
the
want to be
grocery
put under the
store-
microscope. They don't want the scrutiny.
Right. So, and because with scrutiny then comes the opportunity for that to bleed over into public knowledge. So just imagine your grocery store, right?
It
Every
kills
day.
business. At the end of the day, it's a bottom line issue.
Right. So imagine you had, if you had a fight breaking out in your grocery store every day and the police were there, the police are going to want to, the police are paid by the taxpayers and they have their job to do in the public sector. They're not really expecting that they're going to have to come into a hospital that's turning a profit and has the full ability to hire their own security.
Right.
And also just they set their own policies, right? So then it comes back, well, why do you have this 24-hour visiting policy? Why do you have unlimited number of visitors and you don't have waiting rooms on each floor?
Right.
Where are these people going to go in the hospital? They can't all fit in the room. And how do you keep track of all these people roaming through a hospital when you have 200, 400, 500 beds,
Wow.
right? So if there's not, so the hospitals that do really well are the ones that, take your photo when you come in, you sign in, you wear a badge, they're documenting, you coming in, but nothing's really going to prevent somebody who wants to get in from getting in.
Sure.
I can tell you as a former union organizer of hospitals, there's not a hospital I ever found that I could not get in past security. Not a single one that I ever worked, was assigned to in the United States. And there's just so many avenues to get in, to get access in a hospital. There's so many entrances, especially when they're connected to a medical office building. So, and then you've got your ER. The ER is, become the mental health, pit stop, right? This is where people are brought with mental health issues that aren't where they should actually be going to some kind of service where it's specifically addressing their needs, or an ER that is, specifically staffed for psychiatric care, and most are not.
Yeah.
So, you've got overflow happening in ER where you don't even have rooms. You've got patients sitting in the hallway. They're getting aggravated. People are being frustrated in the waiting room. There's all kinds of things. And these things can be mitigated to some degree by actually having more staff. So if you've got somebody who's out there in the waiting room, keeping an eye on things and able to alert security, if you have enough security, and say, hey, this person seems like they're getting a little aggravated. So maybe we need to address that. And it's not always, sometimes just people need to be heard.
Yeah.
Sometimes they just need to be heard. But other times people are coming in and, they know exactly what they intend to do. Other times it could be patients who are somewhat delirious. They're on medications. They don't really know what they're doing. Or they're, there's just a lot of different things that can happen. Again, sometimes it's usually around mental health and drug use. Often is where that happens.
Your expertise is so vast, and you've kind of been in so many different areas of healthcare. What does it look like for someone to work with you directly as a private advocate, as an independent advocate?
Sure. Well, one thing that about all of us is, I would say, as private advocates, is that we're providing a very discreet service, right? My clients are, I will say, on the higher end of socioeconomic status. Most of our clients are, because of our price point and because insurance doesn't cover our services. So, that does kind of create a niche unto itself of who has access to us for the most part at this time. I think that will change in the future. But it means, we do an intake, we have a conversation. Who are you? Are you hiring me for yourself? Are you hiring me for a family member, your mom, your dad, your aunt who, maybe is 3,000 miles away, but you're the only living relative? Again, 20% of people in America are solo agers. 10,000 people turn 65 every day. So the issue of, I don't have anybody who's making my healthcare decisions, or I'm in charge of somebody who I don't even know, right? And I'm in that population, So one is first determining, are you the right person, right? Are you the person I should be speaking with? And is this an appropriate relationship to establish? How can I help you? Do you need clinical support? Which means, I offer clinical decision support. Some advocates do just medical billing. I outsource that. I do medical billing, but I actually contract that out. Um, there's a lot of niches within it because I have clinical expertise. That's what I lean into, as well as my knowledge of regulations. So if somebody's saying, well, my mom is in a nursing home or a skilled rehab and she broke her hip, I have to get the whole background story. Then I've got to look at their insurance. Most people do not know what their health insurance covers, and they for sure have no clue what is covered by a loved one. That's a starting place.
Yeah.
So we do a full history. We start with the top 5 or 6 things, which is, do you have an advance directive? Do you have a medication list listing the names of the prescribers? And also, one thing I ask people is, why do you think you're taking this medication? And how long have you been taking it? And are you actually taking it? Because people will list their medications, but some of them they're not taking, or maybe they take them seasonally. Do you have a list of all your providers and physicians? Do you understand what each of them is doing for you? Is there any overlap? We look at those lists. And then who's your healthcare proxy? Who's the person making decisions for you? Who else do you want to share information? And then we do some HIPAA releases that we sign, so I have access to their healthcare records. Not everybody even gives access. Some people just want the consultation,
Right.
and they want that decision support. So
it sounds like step 1 is you make sense of what's going on. That's
right.
kind of the first thing.
It's really case management, to be honest. I mean, what we are private case managers to some degree, because we're connecting the health insurance, the providers, the hospitals, the facilities, the services available. Somebody might live in, one of these states on the northern part of America where there isn't even a level 1 trauma center, and you've got to go to Colorado if you're in Montana or something, right? And so it's important to let people know, well, do you know what hospital to go to? Do you know how far away is it? Do you know what level of care that they can provide? Because sometimes people are going to say, well, my mom, my dad, my brother, sister, they got transferred 500 miles away. They got airlifted because they were they received burns and there was no burn unit close by. So I help people make sense of things and just simplify what's actually going on, because most people are going to say, yeah, I take an orange pill, I take a purple pill, I take, this yellow pill. And then you find out, oh, well, they're taking 3 medications that do exactly the same thing. So let's just make a relationship with the doctors, the providers, nurse practitioners, PAs, and coordinate all the medications first off. And let's make sure that you know what all of your diagnoses are and that those are also accurate. So, the other thing that I do is I immediately connect with the providers for my clients and let them know, hey, I'm in partnership with you. This is not an adversarial relationship. I'm helping you because I'm going to reinforce the education. I'm going to reinforce the care plan. I'm going to reinforce, what you want this patient to be doing. And then we're going to, figure out, the follow-up, because the other part is people don't do follow-up appointments, come back and see me every 2 months or whatever it might be. So doctors and providers are usually very eager to work with us because they know then they're going to have a more compliant patient. They're going to have better outcomes, which is, right. They want that too.
Well, what's the best way? Is the best way for someone to reach out and work with you just kind of going through your website?
Yeah, that's the best way to reach me is go to my website. My phone number's on there. My email's on there. info@tgpatientadvocates.com. And
so the website, just one more time, a little slower, is tgpatientadvocates.com, right?
.com.
T like Tom, G like good.
Yeah.
Right?
And you can find me also. I'm on LinkedIn. Nurse Adrienne RN is my contact on all the socials. And so I'm on TikTok, Instagram, LinkedIn, YouTube. And, I see that this field is going to really start progressing and opening up. And we're going to just keep seeing more niching in, people really getting into specialties. We're seeing a lot of pharmacists come in now, which is great.
Yeah.
So that's been really exciting because now we have them as a resource. So people are looking to see, hey, how can I make a change, stay in healthcare, and make a difference and still make a living.
It's absolutely fantastic to talk to you and get your wealth of knowledge and experience. It was super informative. I mean, I had never really heard of the violence piece in hospitals, and now I kind of have some research to do. So thanks for the homework.
Yeah.
And I appreciate your time. Thank you so much, Adrienne.
Thank you so much, John. Appreciate it.